I'm going to give you a few facts, and then I will convert this to statements at the end, and then we will vote. So diagnostic imaging is a mainstay of the modern diagnostic process of the spinal trauma. AP-lateral standard radiographs obtained in standard are still basis of imaging. Standard radiography has nowadays additional role, however, because of the CT and MRI imaging being more available and providing more information. MRI imaging is the most commonly used advanced imaging method and is the method of choice in disco-ligamentous abnormalities and the abnormalities of the spinal cord. And CT retains an important role in assessment of trauma, but may not be reliable in demonstrating disco-ligamentous complex, hence secondary and inferior role to MRI scan. And then the ultrasound, PET, CT, and SPECT have no value in thoracolumbar trauma. So simple radiographs. This is the two main directions that we evaluate: AP view and lateral view. On AP view, pedicles, vertebral bodies, disc space, spinous process, lateral vertebral bodies, height, disc space, relations, vertebral bodies, alignment, and paraspinal tissues. A good example of a radiograph showing bulging of the vertebral body suggesting burst with ligament retropulsion. Another good example on AP view, you can see widening of the interpedicular distance suggesting split fracture. So there is I found good level 1 evidence for the value of the CT scan in diagnostication of the thoracolumbar fractures. Up to 20% of the fractures could be missed on the radiographic studies. So CT scan is invaluable and is nowadays a standard for evaluation and diagnostication of thoracolumbar trauma. CT scan positivities include excellent bone acquisition, good for evaluation of bony dimensions and also the spinal canal. It can pick up subtle fractures. It has short time of acquisition. It has excellent 3D reconstruction. Bone window and soft tissue windows are improved, but still not great comparing to MRI scan. The drawbacks, still not good for soft tissue acquisition, not reliable in ligamentous injuries, a relatively high cost if compared to simple radiographs, and it has radiation. A good example of CT scan showing the dimensions of the canal, retropulsion of a fragment, and that corresponds with the radiograph. Another example showing CT scan possible to pick up a very subtle fracture line. Excellent 3D reconstruction. And soft tissue acquisition is improved comparing to the first CT scans, but is still not perfect. And the MRI scan will help in that direction. So the MRI scan has excellent soft tissue acquisition, investigation of choice for spinal cord and nerves, investigation of choice for disco-ligamentous complex, a good vessel acquisition, although this will be rarely evaluated in spinal trauma, different projections of visualization, different protocol for tissue selection, and it has no radiation. Suboptimal bone acquisition is a negative for the MRI scan. Patients with pacemakers and metal implants might be having difficulties. It has longer time of acquisition, high cost, and sometimes is false positive results. There's an interesting paper about the false positive results and incidental findings, which is coming from Scotland. It's called VOMIT and stands for Victims of the Modern Imaging Technology. But there is also a counter statement saying that not all the incidental findings are always trivial. So MRI scan sensitivity is a good thing at the end of the day. MRI scan will be first choice for spinal cord and nerve compression, for discal ligamentous complex, soft tissue lesions, and CSF flow disturbances and CSF leaks. The most helpful protocols for trauma include T1, T2, stir, and fat saturation. With the above, you can easily detect the majority of the lesions of the spine. The mostly used for trauma, gradient echo, stir, and T2, and also axial T1. This is the protocol that the radiology people are using in order to not miss anything. And this could be used also by the neurosurgeons. Good example of MRI scan showing problem with the alignment and retropulsion of a fragment. Another good example of MRI scan corresponding with the findings of a CT scan showing incomplete bursts. And here you have the stir sequence showing the problem with the anterior ligament. With T2, we evaluate the problems with the spinal cord. And so I found a couple of good papers which are important for the statements that I'm going to make, and I'm going to ask you to vote on that. So this is a paper that is evaluating the influence on the additional MRI scan compared to CT scan alone on classification of traumatic spine injuries. So the authors, they have investigated a cohort of patients, and they have found 162 fractures based on CT scan only, and on the same cohort, they have found 196 fractures on CT scan and MRI together. So based on CT scan and MRI scan, the AO classification changed in 31% of the cases. The TILIX changed in 33%. And based on the CT and MRI scan together, the TILIX changed the score from below 5, which suggests conservative therapy, to over 5, which indicates surgical therapy. And in 24% of the patients they have evaluated, this was the fact, and this changed the the management strategy. So this is level 2 evidence. Initially, this was started as level 2 evidence paper, but and it was graded as level 2, but later on it was degraded because of the heterogeneity of the cohort. Another paper that suggests similar ideas. So these authors, they have evaluated 33 patients with X-ray and CT scan, and they have graded based on AO. And then they have found 41 fractures with CT and X-ray. Adding MRI scan to evaluation of the same 33 patients, they ended up discovering 50 fractures and 9 vertebral contusions. So the MRI modified again the diagnosis in 40% of the patients, and it diagnosed that modified the classification pattern in 24% of the patients, and the treatment strategy in 16% of the patients. This is a good paper which has recommendation value, and it was endorsed by CNS and ANS. The authors evaluated 2,278 abstracts, and the conclusion was that the addition of the MRI scan improves detection of the fractures, changes the overall trauma classification, and it's a useful tool for evaluation of the acute thoracolumbar fractures because of the better visualization of the soft tissues and discal ligamentous complex. Again, this is level 3 evidence, and they concluded that more research is needed in order to define the exact place of the MRI scan in a diagnostication of the thoracolumbar trauma. So the statements that I have prepared is the AP lateral standard radiographs are still a basic image that has to be used.
I'm sorry, why are you saying that has to be used? Because according to the guidelines now, we don't use X-rays.
Well, we don't. Yes, there is probably. I was thinking where I don't use that as well. I use only CT scan.
So we can say maybe for a place where they don't have a CT and MRI.
Yes. Okay. Yeah. So thank you for
the help. In the absence of CT and MRI, AP lateral.
Let me. Okay.
So you can start the statement in the absence of.
So maybe AP lateral standard radiographs obtained still represent the basis of imaging if
CT or MRI is unavailable.
If CT scan and MRI scan is not okay. All right.
So why do you say basis of imaging?
Because that's very basic investigation.
So we can say CT, AP lateral standard radiographs may be obtained because basis of imaging used to be about 15, 20 years ago. So if you just keep it simple.
This is definitely like that, maybe in your center, but I was thinking maybe I have to make it a bit more general because surely there is centers where they still rely on.
So we are saying that that's where it's not available, but we can just say that AP and lateral standard radiographs may be obtained if CT and MRI is unavailable in patient with thoracolumbar fractures, something like that.
Delete that still represent the basis of imaging. Imad, yeah, the basis deleted. Okay.
Or maybe we can say it as a. All right, this is good. Maybe you can say secondary role. In the presence of. Keep it simple.
Okay. AP and lateral.
Yeah, this is actually said by the second statement, which says standard. Yeah, maybe we have to vote first.
Update. So there's a comma. Okay. Are you going to say with every sentence for thoracolumbar fracture, or shall we leave it like that? For every sentence. We have the thoracolumbar fracture.
Should I vote as well?
Yes. Be a basis of sending the patient for the CT and MRI. On the basis of that, it would be the burden of and the.
We may not have a trouser to wear, but that's a standard that you wear a trouser. So if you don't have it, you wear a pajama or maybe shorts or whatever you have. But so we say that the standard of care is CT and MRI and a thoracolumbar fracture if you're suspecting it. But if you don't have that, then X-ray used to be done before. So we are just having that sentence just for that underdeveloped, maybe a small town, a village, a small place. We don't do radiographs anymore. When they come to us, they have a CT. They don't have X-rays. Those are the guidelines. So if the guidelines from 2013, WNS, CNS are there.
This comes in the second.
Yeah. So let's come to second.
Yeah. In fact, when you practice in US, anybody who gets a head CT gets a C-SPAN CT. Yeah. With that standard.
It's a routine. Yeah. It's a false one.
It should be the same.
Okay. so standard radiography has nowadays an additional role because of the CT and MRI imaging more easily provide relevant information. I think now one or two maybe are slightly over.
What do you mean by that?
I mean that exactly what you said. It's best to wear pants, but if you don't have pants, you wear pajama.
So shall we write that? Pants and pajama?
I don't know. Maybe not good for work.
We need to vote on that.
Yeah, actually, we can just delete this. This.
The question 2 will be deleted.
To be honest, I was trying to create something that is, state of the art, but on the other hand, just to try to include the rural hospital in, I don't know what, somewhere out there.
I think let's go to 2.
Okay.
You want to read that for us?
Okay, CT retains an important role in assessment of trauma, but may not reliably demonstrate discal ligamentous complex. Hence, MRI addition should be considered.
Yes.
I will change may to can.
MRI should be considered. You don't need to write addition.
Yeah, MRI. Okay. All right. Voting.
Good. Yes. Let's vote.
And then the third, MRI imaging is the most commonly used advanced imaging method and is a method of choice in discal ligamentous abnormalities and abnormalities of the spinal cord. CSF leak or vascular problem that is, let's say, dissection, blood clot or blood clot. Yeah.
Absolutely right. You want to specify it or you want to leave it?
I think you should specify and then we will just say anomalies of the spine. Because that CSF leak, trauma or all of that.
They could be related to trauma. Okay. Yeah.
And other pathologies
Of the spine.
related to.
Yeah, to spinal trauma. Spinal trauma.
Another?
Another pathologies.
And other pathologies.
Yeah.
Okay, that's fine.
Okay.
Let's vote on this.